Hello, you are listening to 1 in 2, a Manchester Cancer Research podcast, brought to you by the University of Manchester and the Manchester Cancer Research Centre. With 1 in 2 of us receiving a cancer diagnosis at some point in our lifetime, it has never been more important for our research to improve the outcomes for people affected by cancer. I am your host, Sally Best, and throughout this series I will be speaking with Manchester cancer researchers about their innovations, discoveries and projects that are changing the landscape of early detection. In this episode, we speak to Professor Gareth Evans about the importance of breast cancer screening, as well as the risk predictors of breast cancer, as he answers the question, should all women be screened equally for breast cancer? So today I'm speaking to Gareth Evans. Would you be able to introduce yourself, Gareth?
I'm Professor Gareth Evans. I'm a consultant in genomic medicine, but also I'm chair of cancer epidemiology and medical genetics at the University of Manchester.
Fab. Thank you. So I guess we'll get started. So we've heard from that you focus on early detection of breast cancer as well as breast cancer risk factors. And I'm wondering if you could please start off by telling me and the audience, why is it so important to screen for breast cancer?
Well, breast cancer screening is important because it's able to detect breast cancer at an earlier stage where cure is more likely. And we know from a lot of information on breast cancer that the earlier the stage, the better the cure rates from those stages. So, for instance, stage 1 is below 2 centimeters in size with no involvement of the lymph nodes. And those patients detected at stage 1 do much better than those at stage 2 and those that where the cancer has spread beyond the breast itself. So the idea of breast screening is to detect breast cancer early. Now, no screening is perfect, so no screening will detect all cancer and have no false positives. In the UK, we do 3 yearly screening from the age of 50 through to 69. In most other organised screening programs, it's 2 yearly screening, and sometimes that starts at 40 rather than 50. The reason that screening before 50 is more problematic is because the incidence is much lower, so only about 20% of breast cancer occurs before the age of 50, and the cancers grow faster and the breast tissue is more dense, which means that you have to actually do the screening more frequently. So from a health economics perspective, it's not cost effective to the NHS to do that screening on everyone below the age of 50.
Okay. So you've said that there's occurrences of some women below 50. And I'm just wondering, would you be able to explain how some of these women are referred for early breast cancer screening?
Yes, so there is a facility for some women to get screening earlier if they meet certain criteria that are specified by NICE, that's the National Institute for Clinical Excellence, and that is if their family history of breast cancer is sufficient for them to have that early screening. And so a typical moderate risk woman would be someone who's got a mother or sister diagnosed under 40, and a typical high-risk woman would be someone who's got a mother and sister both diagnosed before the age of 50. And in those situations, a moderate risk woman would get annual screening from 40 to 50 years of age and be considered for annual screening between 50 and 60. And a high-risk woman would get screened from 40 to 60 every year. Now, there is an exceptional group, and that is those that are proven to carry faults in the main high-risk genes, BRCA1 and BRCA2. They have lifetime risks of up to 80%, 8 in 10 of getting breast cancer, and they qualify for the very high-risk screening program, which is essentially annual screening from 30 to 70, but includes MRI scans of the breast, which are much more sensitive than mammograms, particularly where there are dense breast tissue present, which it is typically the case in younger women. And they can sometimes even qualify for screening before the age of 30, depending upon other risk factors. So that is a tiny group. The high-risk group based on the NICE criteria, is only about 1% of the population, with about another 3% being in the moderate risk group. So maximum of 4% of the population can present to their GPs with their family history and get earlier screening. In reality, less than half of those women actually do that.
Okay, so you've mentioned the women that have the BRCA1 and BRCA2. I'm just wondering if there are other genetic risk factors that increase your risk of developing breast cancer who aren't identified by these hereditary clinics?
Yes, so there are additional genes, although they contribute much less to the situation because they're rarer or are not high enough risk. So there are other high-risk genes, including a gene called PALB2 and TP53, and they would also qualify for that very high-risk screening. And then there is a group of moderate-risk genes which roughly double to treble the risk, giving you a rough 20 to 30% lifetime risk. They wouldn't qualify you for more than moderate risk screening without a significant family history. But additional to those, and much more important on a population level, are what we call polygenic risk. So the individual genes, you just have a genetic fault in those that can increase your risk, but that is less than 1.5% of the population. So less than 1 in 70 women in the general population carry one of those type of genetic faults. But many more of the population can carry common genetic variants, which when taken together push your risk right up. So it's like a pack of cards. You get your single nucleotide polymorphisms, these common genetic changes, one set from your dad, one set from your mum. If you get the wrong deal of the cards, your risk can be high. If you get the right deal of the cards, your risk can be low. And about 50% of the population get a meaningful change in their risk on the basis of a polygenic risk score from these common genetic variants. Whereas actually, on a population basis, only about 1.3, 1.4% of the population would get a meaningful result, in other words, a positive test result from a BRCA1 or BRCA2 gene fault or one of the other rarer genes.
And just for the benefit of our listeners, I'm wondering if you'd be able to describe what is a polygenic risk score and if you have any analogies that would be able to encompass a risk score for women for breast cancer.
So what we do in a polygenic risk score is we assess genetic changes called single nucleotide polymorphisms. So these are literally just a single letter change in the genetic code. And these may be in genes or they may actually be between genes. So they don't have to be an actual change in a gene. And at the moment, we're using scores of up to 313 of these genetic changes. Now, some of these changes may increase the likelihood of breast cancer slightly. Some may reduce them. So individually, they're of no real benefit. But when put them together, you can end up with a risk which is 3 times the average, or a risk which might even be 3 times less than the average. And it's a bit like, as I said, getting a deal of cards. You might get a fantastic hand full of aces and kings. That means that in poker or in bridge or whist, you're going to win the hand. So you're not going to get breast cancer because you've got such a strong hand. You might get a terrible hand, which means that the likelihood of you getting breast cancer substantially increases. And every time you shuffle the pack, you will get a different deal from the 2 parents that have their children. And that means that the polygenic risk scores can be substantially different from parent to child or even sister to sister. So, for instance, I've seen 2 sisters, one of whom had a 2-fold increased risk, doubling of her risk. The other sister had a halving of her risk. So those sisters had a 4-fold difference in their risk of developing breast cancer, which is an enormous change. That isn't because one had BRCA1 and one didn't. it's because their polygenic risk score was substantially different between one and the other. The important thing about this is that we identify this very low risk group, which doing the standard gene testing for BRCA1 and 2 doesn't give us. Being negative or having no fault in those genes does not really reduce your risk unless you've got an incredibly strong family history. So there is very little benefit of a negative test for all of the moderate and high risk genes, BRCA1, BRCA2, etc. But there can be huge benefits from doing a polygenic risk score in terms of identifying women at very low levels of risk.
Yeah, it's really interesting to hear. I mean, I'm quite surprised. I don't know if the listeners would also be surprised about that variability between family members and risk. I was under the impression that it was kind of a continual spectrum of your mother was at high risk, you're at high risk, or your sister's at high risk, you're at high risk. And I guess it's interesting to hear, but I think it also highlights the importance of screening to differentiate between even family groups. So just kind of leading on from this genetic risk side of things, your research looking at saliva tests for breast cancer has recently been spotlighted in The Times and the Daily Mail, and also in Julia Bradbury's documentary Breast Cancer and Me. And it's been described by Health Secretary Sajid Javid as promising new research, and I'll put the links in for the listeners that are interested. They're kind of very good reads. But I wonder if you'd be able to tell me more and tell the listeners more about this research and the results of this recent study.
So what this study does is it brings together all of the known risk factors. So what we call standard risk factors, those are things like when your periods start, when you have your first child, how many children you have, when you have your menopause, taking HRT, etc., your BMI, in other words, your weight, and particular weight gain is the most important thing. And it takes together those standard risk factors that can be put together in a risk tool with two actually much more predictive factors. And those are the polygenic risk score, which I've just described, and breast density. And we now know that the bottom 10 to 15% of the population has a risk 5 to 6 times less than the top 10 to 15% of the population based on assessing the density of the breast tissue on a mammogram. Now, what we're looking for is on a mammogram, the white areas, which represent the glandular breast tissue and fibrous tissue, and that is the risky tissue. So the less of that you have, the less risk there is. The more of the risk you have, the more risk there is. The other factor with breast density is that it can mask your breast cancer. So there are two elements to the risk. One, it's a higher risk that the mammograms won't pick up your cancer early, but also it's a higher risk overall that you'll get breast cancer. Now, we can now put all of those three factors together to come up with a 10-year risk and a lifetime risk of getting breast cancer. So we can really accurately risk stratify the population into low risk groups, which have a very low risk of breast cancer, and high risk groups, which have a very high risk of breast cancer. Not only that, a higher risk of cancers that are likely to be later stage, so not so easy to pick up on screening, which means we need to do the screening more frequently. And so what we've shown in the study is that we can identify about 20% of the population who are in these moderate or high risk categories. That is a 10-year risk of 5% or greater in the screening age group, 8% or greater for the high risk group. And those 20% develop nearly 50% of all the stage 2 cancers. So by identifying that group, we can potentially downstage half of all breast cancers, but also potentially prevent those breast cancers by those women taking medication or doing lifestyle factors which will help reduce their risk.
I'd like to touch on that in a bit, but I'm I know that you've been working on risk stratified screening, and in particular studies such as PROCAS 1 and PROCAS 2. And I'm wondering if you'd be able to provide a bit of a background to those studies, what they've been looking at, and then how they differ to this one-size-fits-all screening that we currently see in the NHS.
So what we've been doing is looking at really the whole totality of the risk, and we know that, for instance, lifestyle factors do affect the risk. In particular, it's weight gain. So the more weight you put on from your sort of early adult weight at, say, age 18, 20, the more that increases particularly your postmenopausal risk. So the risk after your menopause, which is typically 51, 52 years of age when the periods have stopped. And that is the main period of risk. So over 80% of the breast cancers occur in postmenopausal women. And what we've been able to do is look at the risk factors, also look at, as I've said, breast density and the polygenic risk scores. And this allows us to really accurately divide up the risk. Also to be able to advise women who are at most risk that they can reduce their risk by, if they've gained weight, by losing that weight. We're not trying to get women to go back to weights below they were when they were 18 or 20, but if they can approach the risk, the weight when they were 18 or 20, that will very substantially reduce their risk if they put on a lot of weight. So these are factors that we can use in that. Now, in terms of the risk stratification, at the moment, as we said, nearly every woman is offered screening only 3 yearly from the age of 50. And probably only about 1.5% to 2% of the population come forward because of their family history and get more frequent screening before the age of 50. What we've shown is if we were to do a risk assessment at, say, age 30, we could detect 9% of the population at high risk and about 11% of the population at moderate risk who would qualify for that early screening. So we would increase the proportion of women eligible for that early screening by about tenfold, and we would have a much greater impact on picking up breast cancer early. Not only that, we would do more frequent screening for the women at high risk, so 9% of the population, 1 in 11 between 50 and 60, downstaging potentially those cancers. There may even be a case for more frequent, maybe 2 yearly screening in the moderate risk women. And there may even be a case for reducing screening, maybe starting it a bit later in women at very low levels of risk. So by combining all of these measures, we can very accurately risk stratify. And the important thing in the low risk group is that there is a much higher rate of effectively overdiagnosis. So cancers that may never present clinically being a higher proportion of their overall cancers, but not only that, their likelihood of developing a stage 2 cancer is much lower. So potentially the overdiagnosis, the overtreatment of these women, the fact that they're getting more biopsies when they haven't got cancer, are things that are downsides of screening, which can potentially balance much better the risks and benefits. So more frequent screening in those at higher risk, maybe slightly less frequent screening in those at very low risk, but maybe starting their screening a bit later. And these are things we're exploring with women themselves who are identified that they are at low risk.
Okay, so you've talked about women that are identified at higher risk. They can take precautionary measures such as kind of looking at their BMI and then having this increased screening frequency. I'm just wondering if you'd be able to talk about the preventative medication side of things and how that links into some of the studies that you've done.
So there are now 3 medications that can be taken to reduce the risk of breast cancer. The most commonly used and commonly known is called tamoxifen. And that is a treatment that has been used for over 40 years in women with breast cancer. It blocks the estrogen receptor on the breast tissue, and that has been shown to significantly reduce the risk of breast cancer in women with breast cancer in their other breast, their unaffected breast. But also in clinical trials, it's reduced the risk of breast cancer by about 30 to 40% in women who don't have breast cancer in the first place. So it is now recommended for NICE, particularly for women before the menopause. After the menopause, there are two additional drugs that can be used, and these are raloxifene, which is also a blocker of the estrogen receptor, but has a few less side effects than tamoxifen, but unfortunately isn't quite as effective at prevention. And then there is anastrozole, which is an aromatase inhibitor, and that drug actually stops you producing estrogen after the menopause. You do produce estrogen from your fatty tissue and your adrenal glands, and it's able to reduce that level that's produced. So anastrozole is even more effective than tamoxifen, reduces the risk by about 50%, and also has less side effects. The important side effects that tamoxifen potentially has that make it less suitable after the menopause is it increases the risk slightly of getting cancer of the lining of the womb, whereas anastrozole does not do that. And there's a slight increased risk of blood clotting, and anastrozole has much lesser of an effect of that. So overall, although there are some side effects with these medications, they are very, very effective at reducing risk. And NICE recommends offering these treatments, tamoxifen to premenopausal women, anastrozole to postmenopausal women who are at high risk, and considering them for women at moderate risk. And NICE has shown in a health economic assessment that actually taking anastrozole, because it's so inexpensive, about 2 or 3 pence a day, is actually cost saving to the health service, because the treatment of cancer is so expensive that actually stopping those cancers occurring saves the health service a huge amount of money. But I think as importantly, if not more importantly, saves women the hell of going through a diagnosis and all of the treatment that's involved in a breast cancer.
Okay, and are any of the researchers that were involved in this that were from Manchester?
Yes, so in fact, a lot of these trials were led from Manchester. The IBIS-1 trial was led by Professor Tony Howell as the lead clinician for the whole study, as was the IBIS-2 trial, which led the anastrozole, that assessed anastrozole. So both of those trials were led from Manchester. And in fact, both myself, I was on the NICE guideline, along with Sasha Howell, Tony Howell's son, which came up with the final, most recent guidance in 2017 recommending the use of these treatments. And the important thing is you take the treatments for 5 years, but they actually give you protection for at least up to 20 years with tamoxifen. So they continue to work after you've stopped taking the medications. And the really interesting thing that we haven't published yet, but from our BC Predict study, is that these are women who we've assessed in the last 2 years, where we've given them their risk feedback immediately after they've had their mammogram. Once they're clear on their mammograms, about 6 weeks after, they're given their risk. And of the women at high and moderate risk that have come forward to have a discussion, nearly 80% of the high-risk women have gone on to risk-reducing medication, which is really, really an astonishing result, because typically we're only getting around 10% of women onto risk-reducing medication through the family history clinics. And it may be that it's this fresh realization of risk that prompts women to do something additional, whereas women that have been living with the knowledge of their risk for so many years are perhaps less willing to consider risk-reducing medication. And in fact, women at high risk as a result of family history, are much, much more likely to go down the route of risk-reducing surgery, particularly if they carry a fault in BRCA1 or BRCA2. About 50% of those women, by about 5 or 6 years after their result, choose to have risk-reducing surgery.
Fab. So just kind of touching on the risk side of things. So your BC Predict and PROCAST 1 and PROCAST 2 looked into the potential of offering women this risk stratification of their risk of developing breast cancer in the next 10 years. So I'm just wondering, what are some of the potential disadvantages of telling women they are both either at higher or lower risk of developing breast cancer?
So I guess the main potential disadvantage, and I'm saying they're potential because we think actually they're not such a disadvantage as our study is showing, is that women who are told they are high risk could become very anxious and have a great deal of cancer worry. And that might be actually something that is strangely a disincentive for them doing anything about it. They may feel that it's going to happen to me anyway, I just don't want to know. And the women at low risk might be falsely reassured that low risk means no risk and might detach themselves from any sort of monitoring, having any sort of mammograms. And we've found in PROCAST 1 that those women actually do not detach themselves, that they're just as likely as average risk women to continue with their screening, and that has recently been published in the Breast Journal. But in PROCAST 2, we've shown that there really is no significant increase in either breast cancer anxiety or risk concern in the moderate and high risk groups. And in fact, many of the women who were found to be high or moderate risk already had a perception that they might be at some increased risk of breast cancer. So their perception of risk was already higher, possibly due to family history and other risk factors that they knew about.
Okay, I guess it's really interesting to actually look into that multidisciplinary side of the research and look at the health psychology as well as the actual science behind these diagnoses. And I guess leading on from that, I'd like to ask what your vision is for breast cancer screening by 2030. And we've heard about Sajid Javid's War on Cancer, but I'm wondering, personal to you, what that vision would be for breast cancer screening.
So my vision would really be that all women are offered a risk assessment when they're 30 or around the age of 30, because breast cancer is vanishingly low before that point. And we can do a lot of the breast screening starting from 30 or at least 35. We've shown that screening is actually effective and reduces mortality in women between 35 and 39, for instance. And if we did that, we would identify about 1 in 5 women who would qualify for early screening. They would qualify potentially for taking tamoxifen before the menopause, and we could substantially reduce the mortality from breast cancer in that group of women by that combination of taking preventive medication and early detection. And that then women would be reassessed at the age of 50, when screening would normally start, to assess what their screening would be going forward from that point onwards. Would it be every year if they were high risk, as recommended by NICE? Would it be every 2 or 3 years, or maybe even every 4 or 5 years if they were very low risk? And it might be that we would say, well, you know, your screen at 50 is fine. We will, if you're very low risk, bring you just back in 5 years and reassess things. But give women the option, if they feel they have developed an additional risk factor, to have their risk reassessed. So, for instance, their family history changes, a sister's diagnosed with breast cancer, that might affect their risk assessment. Although going forward, the genetics is accounting for more and more of the inherited component. So eventually we may not even need family history to assess risk because we're assessing that already in all of the genetic testing that we're doing.
Okay, so you've got PROCAST 2 that's in its review stage at the minute. What would be the next stages that you'd look at with that study to enable this progression to your vision of screening?
So we have a study that's in setup at the moment, which is a young women's study where we are going to offer a low-dose mammogram, about 1/10 of the dose of a normal mammogram, to assess the breast density and to do the polygenic risk score and potentially the test for the other genes, as well as using the standard risk factor. So this would be a study that would potentially legitimize the idea of doing a much earlier screen to determine risk. And I think, going forward, we would hopefully, and there is other research which will be coming out from the MyPEP study, which is doing actual risk stratified screening, changing the risk, changing the interval of screening to 1 yearly in the very high risk and the high risk, staying at 2 yearly for the average risk, and then going to 4 yearly for the low risk, and the Wisdom study, which is similar in the States, and going to the national screening program, assuming that the data continue to back up this risk stratification, and saying, look, we need to be doing this. And going forward, that would be, I think, an initial assessment, as we say, around 30 years of age, and then a second assessment at around 50 years of age. So women who were already approaching 50 would get that first assessment in that 50 age group. Women who were in their 30s, I would think we would have to work through that population slowly to make sure that eventually we got to the situation where every woman had been offered that risk stratified approach, at least up until 60 years of age, and that we then just did those two main assessments, one at 30, one at 50, potentially one more at 60. But again, the research will tell us if that is the right way to go forward. And we would have a fully, not one size fits all, where we can offer this screening. And importantly, and I've just looked at this data, the idea that you need a family history to be high risk, of all of the breast cancers we've picked up, when we use all of the risk factors together, half of the women who develop breast cancer who we classify as high risk have no family history of breast cancer at all in either first or second degree relatives. So it's really important that women don't think they can't be at high risk because they don't have a family history. There are many other ways they can get there. The genetic factors may not have shown themselves in other people because it's a deal of the cards. It might be different in you to your previous relatives, and your mammographic density may be different, or your relatives just may have been lucky. So, for instance, we know you can carry a fault in BRCA1 or BRCA2, and there be no family history. So, again, no family history is not immunity from risk. It just means overall the likelihood of your risk is to be lower than someone who does have a family history.
Okay. Finally, to summarize, and I guess we've kind of covered it, but it's to get that kind of 2-second snippet of should we screen all women for breast cancer?
So I guess the standard answer is yes, we need to screen women for their risk first. So that's the screening test. I think there may come a time where we will identify women at such low risk that those women may decide themselves that it's not worth them having the screening. It's a little bit uncomfortable. The chances of false positives will be so much higher than the chances of getting cancer that they just decide, no, I'm not gonna have it. Maybe there'll be a better test, like a blood test that doesn't have the same false positivity that mammograms have. So, At the moment, yes, every woman should be screened or be offered screening. We can't force women to obviously get breast screening, but the evidence suggests that risk stratified screening is much better at balancing the benefits and the disbenefits of what screening does. And that may mean that we do less screening, that we start screening later in those women at lower levels of risk. And it may eventually mean there'll be a group of women at such low levels of risk that we just stop screening altogether for them.
Okay, fabulous. I'd like to ask what's made you curious about breast cancer and breast cancer research?
So I guess sometimes it's where you end up rather than what you necessarily had in mind. So I was a pediatrician and I became very interested in genetics. I was interested in genetics at medical school. Didn't realize there was an actual profession in genetics. So while I was a pediatrician, I discovered that you could be a clinical geneticist. So I then looked around for jobs. I was actually in the army at the time as a pediatrician, and I went for a job interview in Manchester for a clinical research fellow. And the job of that clinical research fellow was to set up cancer genetic services in the northwest of England. So my remit was essentially to develop services for people who are at increased risk of developing cancer. So there are syndromic cancers, but by far the biggest demand was from women who were worried about their risk of breast cancer. I started this in 1990, and in that year, the BRCA1 gene was identified as being on chromosome 17. The TP53 gene was identified as a cause of Li-Fraumeni syndrome, and they have the highest risk of breast cancer with TP53 gene faults up until the age of about 50. And I was really fascinated to work with women to understand how women perceived risk, how they understood risk, because I was talking to them about risk. And that's really how it all started. And I've worked on breast cancer and breast cancer risk since the 1990s, initially just on women with a breast cancer family history. But from 2009, we decided that we would look at this on a population basis, and that's how the PROCAS study was started, that I put in an application to the NIHR, and we got a 5-year program grant, which is PROCAS, Predicting the Risk of Cancer at Screening. And it's that study, which recruited 58,000 women, that has really given us huge information. That's the study that's shown us what proportion of people are moderate or high risk and what proportion of the cancers we can pick up. It's shown us what happens to the screening going forwards. It's shown us about the weight gain issue. These are all factors that have been born out of that. But really, as soon as I had the opportunity to work in the breast cancer field and to develop the services for breast cancer in the Northwest, I was hooked, and I've wanted to help women who have that risk going forward since 1990.
What an answer. And I think, listening to that and listening to all the work that you've done, it's a lifetime worth of work, and there's a lot kind of behind it. And I guess my kind of final question would be, what continues to inspire you in breast cancer research?
What inspires me is the women themselves, the women who come forward and want to know about their risk, what they can do about their risk, the women that go out there and raise the money that allows me to do a lot of the research that I do. But it's also that discovery factor. It's looking at the data and saying, gosh, I've just found something that's going to be important going forward. So I'm inspired by being able to identify things that are important, identify risk factors, and identify things that we can do. The more and more we can do, the more we have in our armamentarium to to try and prevent deaths from breast cancer. And preventing deaths from breast cancer is about prevention, but it's also about early detection. And so working with those two together, I think we can make a fantastic contribution to reducing the 11,500 deaths per year from breast cancer, especially if we can get in and do this assessment earlier in the early 30s. That is the stage where women are losing more life years. They're dying when they have young children. We should be trying to prevent those breast cancers because that's really where the most is lost.
Great stuff. I want to say thank you ever so much for speaking to me today. It's been enlightening for me, and I hope for the listeners as well. And I'll link all the references that we've made in this discussion. But honestly, thank you, Gareth. Very inspirational. And it's been great chatting to you.
It's a pleasure. Thank you.
If you have been affected by anything you've heard in this episode, please see the show notes for a list of charities and organisations that can help.
1 in 2 was brought to you by the University of Manchester and the Manchester Cancer Research Centre. Listen to our next episode to hear from more of our researchers as they share the innovations, discoveries and projects that are changing the landscape of cancer prevention, early detection and treatment. To find out more about what you've heard today, please see the show notes for this episode, where you'll find a transcript and links to further information and research. Cancer is one of the university's 5 research beacons, showcasing the interdisciplinary collaborations and cross-sector partnerships that are tackling some of the biggest questions facing the planet. To hear more about Manchester's research in advanced materials, biotechnology, cancer, energy and global inequalities, go to manchester.ac.uk/beacons.